So today we'll talk about aspirin use and the prophylaxis for prevention of preeclampsia. My objectives are to kind of just barely touch on the basis of preeclampsia, to review the mechanism of aspirin and the theory of how it can help prevent preeclampsia development, to look at the literature regarding aspirin use for prevention of preeclampsia, and then to review the recommendations set forth by the United States Preventative Services Task Force and ACOG. This was the whole reason I decided this topic was the ACOG practice advisory that came out in July. They supported the use of low-dose aspirin daily for people with high risk factors for developing preeclampsia. So it kind of struck my interest. I kind of worked backwards, looked at this advisory, saw their sources. They came from the USPSTF. I'll try not to say that too many times. And they got, they put a different sources out, so that kind of why we're here. So preeclampsia briefly is new onset blood pressure elevation and new onset proteinuria after 20 weeks. The old definition, we used to use 300 milligrams in a 24-hour urine of protein, or now we can use the protein-creatinine ratio of 0.3 grams per deciliter. But now with the new guidelines, you don't necessarily have to have proteinuria if you have new onset hypertension plus thrombocytopenia, elevated LFTs, renal insufficiency with serum creatinine greater than 1.1, or doubling of the serum creatinine, pulmonary edema, or cerebral disturbances. So I think most know you have to have two measurements of blood pressure greater than 140 over 90. Some sources say 4 hours, some say 6 hours apart. So briefly, preeclampsia, it happens in about 4% of pregnancies, depending kind of on the risk, but in general 4%. It accounts for 15% of preterm births, and it's actually the leading cause of medically indicated preterm deliveries. It has a really big impact on both the mom and the baby. For a baby, you can end up with IUGR, poor placentation that isn't really given much oxygen to the baby. Small for gestational age, abruptions, NICU admissions, or even death. And so the only definitive treatment is delivery. So there's a lot of research going on to try to attempt to prevent this disease rather than, there's no other treatments necessarily. This was straight out of Creases. It's just a box of the signs and symptoms. It can affect almost every organ system. And these are some of the signs and stuff we look for. The preeclampsia risk factors, they say most of the time that that nulliparity is the highest, the most important risk factor. Also, previous history of pre-E, obesity, a family history of pre-E in some sources, diabetes, hypertension, chronic kidney disease, any renal insufficiency, advanced maternal age, or autoimmune diseases like lupus and antiphospholipid syndrome. And so the pathophysiology behind preeclampsia is pretty complex. They have, many different areas coming in. Certain patients have certain risk factors that contribute to their disease. Some have multiple risk factors. So we do know that early pregnancy, they usually have an abnormal placental development, resulting in ischemia, resulting in inflammatory mediators and oxidative stress factors to be circulating in the maternal blood. And then also pre-existing conditions like diabetes and hypertension, things like that, can lead to poor placental perfusion, which the same thing can activate the inflammatory responses or oxidative stress pathways. This is just kind of a slide that kind of shows everything. You have all the genetic factors, the pre-existing factors, the poor placentation, the stress, inflammation that leads to chronic ischemia and hypoxia. That results in the release of different mediators and oxidative stress, leading to endothelial dysfunction. And one of the main things that this talk kind of looks into is the fact that the endothelial dysfunction produces an increase in the thromboxane levels. And so aspirin actually inhibits the cyclooxygenase that is used as the enzyme to make thromboxane. So in theory, if we reduce so they say there's an imbalance in preeclampsia. There's an imbalance for the prostacyclin levels and thromboxane levels. You end up getting an increased amount of thromboxane. Prostacyclin is a vasodilator, inhibits platelet aggregation. But thromboxane's a vasoconstrictor, can lead to vasospasm. It aggregates the platelets, so it's not good. So, like I said, aspirin inhibits the synthesis of thromboxane by inhibiting cyclooxygenase. This is just a little slide of the mechanism. So, of course, platelet aggregation we know can lead to thrombosis. You can get infarction of the placenta, things like that for this process. So, looking at the data, at first, so when it came out, a lot of the studies were very small. Only 100 or 200 patients. That they actually had these big results that aspirin was so great. So this was a study out of the OBGYN department at a medical school in Israel. And so what they did was they took patients that were high risk for preeclampsia, which they screened for nulliparity, multiple gestation, and a history of pre-E. And they grabbed, I think it was 791 women, and they did a rollover test. They basically put them on their back, then rolled them over, took their blood pressure, and kind of see what type of response. First, they took pressure on their side. So they called a test positive if the diastolic pressure increased by 15 beats per minute. And so of the 791, 65 had a positive test. And so that was what their study group was. And then they took 104 patients that were left over that had the negative test and made them their control group or their low risk group. And so then they randomized those 65 patients and put them into a randomized double-blinded study. Half of the group got 100 milligrams of aspirin, half of the group got a placebo. So then basically, also another thing they did, they before the test they got serum levels of the metabolites of prostacyclin and thromboxane, and they did, of course, normal follow-up like blood pressures, urine dips, serum levels of those metabolites at 3-week intervals. And so the results were that pregnancy-induced hypertension, there was in the treated group, aspirin-treated group, there was a 11.8% reduction in preeclampsia versus the placebo. I'm sorry, that's just their rate. The rate of hypertension was 11.8, and then the placebo they had a rate of 35%. And then for preeclampsia, or what they used to call toxemia, they had the aspirin group only developed preeclampsia in 3%, and then placebo was 23%. So that's a pretty big number according to this study. Also, they looked at they measured the thromboxane and the prostacyclin metabolites frequently and looked at the difference. So after 3 weeks of the treatment, the aspirin group actually had a decrease in the ratio, meaning they had increased thromboxane levels, so it decreased by 34%, and then the placebo, it actually increased, meaning they had a much higher thromboxane level. And then so what they concluded from this study was basically that low daily doses of aspirin taken in the third trimester actually reduced the incidence of hypertension and preeclampsia in these women. And so considering the amount of thromboxane that the ratio and how it increased in the placebo group, they decided, well, that's probably how it's working. It's actually blocking the thromboxane. So next, this is a study by Dr. Sabai out at the OBGYN department in Memphis. And he criticized a lot of the studies and says, well, sure, you're going to find a difference. These are really high-risk patients. Let's look at some low-risk patients and see what happens. And so they did a double-blinded placebo-controlled trial, again with nulliparous women, 13 to 25 weeks, and they had to have a normal blood pressure with no protein. And so 35 women were in this study, and they received either aspirin or the placebo. And so his results were, for preeclampsia, there was only 5% developed in the aspirin group versus 6% in the placebo. So they're saying that the risk is actually reduced in the aspirin group. And then the But one thing that they did find, they looked at different outcomes in the pregnancy, and they found that there was an increased risk in placental abruption in the group that was receiving aspirin. So they made this statement saying, sure, aspirin can help, but actually, why should we really use it? Because it increases the risk of abruption. And if you look at the numbers, I mean, that's a really low number. Only 2 in the placebo group, 0.1% abruption. That, I mean, if the normal abruption rate is about 1% of pregnancies. And so one thing that they did find in this study was that they got their initial blood pressures of all the patients, and the patients who had a starting blood pressure of 120 to 134 actually had the best decrease, I guess, in incidence of preeclampsia. So in the black is the placebo group, they had a 12% incidence, and then if you look on the 120 to 134, they just had a better response to the aspirin treatment. So they looked at all the other outcomes in the pregnancies, like oligo, PPROM, preterm deliveries and postterm deliveries, and they found no difference. They had a similar incidence, and then there was no difference in the rate of C-sections. Average gestational age was the same at delivery, birth weight was the same, length of delivery was the same. So not much from that. So they concluded, again, that low-dose aspirin does decrease the risk of the incidence of pre-E on the nulliparous women, but primarily in those who had an elevated systolic blood pressure initially. That was still normal, but elevated, 120, 135. And then they also said aspirin does not decrease perinatal morbidity, but it does increase the risk of placental abruption. I don't. I just think that those, like I said, the numbers of 0.1% in the placebo group of abruption is really low.
Well, I mean, honestly, we don't know what the answer to that is, right? Because, I mean, you told me the risk for an abruption is about 1 in 125 patients, but we look at groups overall, we group everybody together, we don't know what it is in a low-risk population. It makes sense that it's lower. Does that make you see what I'm saying?
Yeah.
So nobody's ever looked at it to see what that is, what the number is.
Yeah. So next, then they kind of, again, made the decision, okay, well, these are all really low, there's low numbers of these studies, they're showing such a difference, so they did a larger study with patients who are high risk. This was by the MFMU, it was published in New England Journal of Medicine in '98, and they did a double-blind randomized. This was out of 13 different U.S. sites, a bunch of different hospitals. They got 4 high-risk patients, or groups of patients, and enrolled them between 13 and 26 weeks. So the 4 were either pregestational insulin-dependent diabetes, chronic hypertension, multifetal gestation, or pregnancies, patients who had a previous pre-E in their pregnancy. And so it ended up coming down to about 1,200 in each group, 60 milligrams of aspirin in one group versus just the placebo in the other group. And so their results, they found that the aspirin group, the incidence of preeclampsia was 18% versus the placebo was 20%. So it was not a good p-value. They said this isn't a difference. And then the incidence for each 4 risk group was similar. I thought this was a good, show you the risk of patients who have pregestational diabetes. I mean, they're about 18-20% risk of developing. So I thought this was a cool to see how high the risk is of developing preeclampsia in these conditions. So the results, the incidence of perinatal death, preterm birth, and infants small for gestational age were similar between the groups. They had concluded after the study that low-dose aspirin did not reduce their incidence of preeclampsia significantly, and that the perinatal outcomes weren't really improved at women with high risk for pre-E. So then one of the next, largest studies was the CLASP study, randomized trial of low-dose aspirin for prevention and treatment of preeclampsia. And this was over 16 different countries over like 5 years. They had 9,300 women from 213 centers, randomly assigned 60 milligrams of aspirin or matching placebo. And so this was a little bit different. They had people who were entered in prophylactically because they had a high risk for developing preeclampsia, and then some for prophylaxis of IUGR just because they have a history of it. And then they had patients who actually went in for treatment. So they put them in the trial for treatment of pre-E or treatment of IUGR. Because they said, okay, well, we assume that there's probably a lack of perfusion of the placenta caused in pre-E and then probably also in IUGR, so they thought they could just include it all into one. And so the results, the use of aspirin was associated with a reduction of 12% in the incidence of proteinuria preeclampsia, which was not significant. It's 6.7 versus 7.6. No significant effect was measured in the prophylactic group versus the therapeutic group. There was no effect on the incidence of IUGR, stillbirth, or neonatal death. But they did notice that there was a reduction in the likelihood of premature delivery, so 19.7% versus 22%. And then there was no significant increase in placental hemorrhage, which is what people were worried about as far as having increased bleeding risk to the baby or to mom. And there was no difference in bleeding during the epidural. So they concluded in this study that the findings again did not support the routine treatment of aspirin in pregnancy for these patients. So then they did a Cochrane review in 2004 on antiplatelet agents, and they tended to actually use kind of a mixed population of high risk and then kind of lower to medium risk. And so they had 59 trials, and it was about almost 40,000 women. It was all the trials had to basically compare antiplatelet agents versus just a placebo or no agent. And they found with the results that there was actually a 17% reduction risk in the risk of preeclampsia. And so they kind of concluded with that was that, well, if you look back at the numbers of the other studies, technically there is a lower number, 6.7% in the aspirin and 7.6% in the placebo, and then the other one was, the aspirin group was technically a lower number, 18-20. They said, well, if we keep on adding these up and the aspirin numbers are always smaller, that it may actually make a difference. And so they did find, though, that there was actually a trend towards, there was actually a bigger risk reduction for patients with a higher risk compared to moderate risk. So they ended up getting the prevalence or the incidence of the disease and found that the number needed to treat for low-risk patients was about 500 to prevent one case of preeclampsia versus 50 for the high-risk group. And then this was more of the results from this Cochrane review was that there was an 8% reduction in the relative risk of preterm birth, 14% for fetal neonatal death, and 10% for small for gestational age. And they kind of assumed that, well, this makes sense if we're reducing the risk of preeclampsia, then all these associated comorbidities or problems for the babies should also be reduced. And so their conclusion for the Cochrane review was that antiplatelets do actually have a moderate benefit to use for preeclampsia. So this is the big one. This is, ACOG said, well, we went to the preventative task force, and so they actually did a systematic review. First, they had one in 1996 where they just looked at the reduction of preeclampsia associated with aspirin use. And they didn't find enough evidence, and they actually put out a statement saying, we don't really support it, we don't find a difference. And so then in 2014, they actually repeated it. They did reviewed again the efficacy of aspirin to reduce the pre-E. They looked at aspirin and decreasing adverse maternal and perinatal health outcomes, like we said, so like IUGR or bleeding problems with mom or abruption, things like that. And same thing, maternal fetal harms of low-dose aspirin during pregnancy. So those were like their three main goals. And so they got several randomized controlled trials. They had 2 large multi-site, which were the 2 that I actually talked about earlier, and then they had 13 smaller ones for just high-risk patients that were included. And this is regarding like just the aspirin use and the efficacy of it. And then they had additional 6 randomized controlled trials and 2 observational studies to actually look at the average risk of women and the harms that were to mom and baby. And so the incidence of pre-E ranged, of course. There was a mixed population from 8 to 30%. And then they did notice that all the trials did initiate aspirin between 12 to 16 weeks. And like I said, the majority was from the MFMU trial and the class study that I already talked about. So what they actually found in their results were that pre-E was actually, the risk was reduced by 24%, preterm birth by 14%, and IUGR by 20%. They didn't find any difference when they actually looked at the timing of aspirin, like what actual gestational age it started, and they didn't find any difference with dosage. The average dosing was between 60 and 150. And so studies a long time ago used to use higher doses of aspirin, but they found, much higher risk of bleeding and other issues, so they've been using lower doses. And they did find that the mean birth rate increased by 130 grams in the babies, so they assume that, again, pregnancies are being prolonged because of the reduction in pre-E, reduction in preterm birth, all those things. There was no significant reduction in perinatal mortality. There was no significant increase for abruption, which was, they claimed earlier for the other study, postpartum hemorrhage, or fetal intracranial bleeding. And then they looked at blood loss at delivery, and they didn't find a difference at blood loss. You'd think, give it to my aspirin daily, but no. So they also calculated a number to treat, and they said to prevent one diagnosis, you have to treat 42 patients to reduce the risk, to prevent one case of pre-E. So they concluded that there is good evidence that aspirin does reduce the risk for pre-E, preterm birth, and IUGR. They said there's no increased risk in abruption, postpartum hemorrhage, bleeding, or other mortalities. They said, okay, well, we recommend 81 milligrams per day because that's just in the U.S. the dosage it comes in. And they say you should start it after 12 weeks of gestation in women with high risk for pre-E. And then they define the high risk group. So again, this is kind of like the thing we have in clinic, history of pre-E with the adverse outcome. So I would think a really early diagnosis of pre-E, probably like late second trimester, early third, or IUGR in that pregnancy with preeclampsia, things like that, or eruption related to the preeclampsia, multifetal gestation, chronic hypertension, diabetes, type 1 or 2, renal disease, or any of the autoimmune diseases. And so in all those patients, they recommend that you need to start if they have any of those risk factors. And then they say, well, it makes kind of sense if we have patients who have a moderate risk factor, like nulliparity, obesity, history of pre-E, or they have their AMA, things like that, you can consider it if they have enough moderate risk factors. So someone who's had a strong family history of it, and she comes in and she's 40 years old, maybe you would consider doing aspirin for them. And then they say anyone who's low risk, we don't recommend it. So again, this is the ACOG practice advisory. They say anyone who has a history of pre-E, but mostly, not necessarily just they got pre-E at 37 weeks or 38 weeks and we delivered them, but people who've had adverse outcome. Multifetal gestation, chronic hypertension, diabetes, renal disease, or autoimmune disease. So that's what their recommendation is. So in conclusion, the preeclampsia, they say it's well known that there's a problem with the systemic levels of prostacyclin and thromboxane ratio, and that low-dose aspirin blocks the production of thromboxane, so it should help with that. And then again, the several small earlier trials did show a protective effect, but then the randomized trials didn't. And then the Cochrane analysis found a reduction of 17% in their meta-analysis in preeclampsia development, and then the task force found a 24% reduction. And so both of those, the ACOG and the task force both recommend aspirin use in high-risk patients, sorry. So everyone gets to put a picture of their babies, so that's my one-eyed baby. Questions? Concerns?
What'd you learn?
I learned that I thought it was kind of crazy that the data was so just completely changed throughout time. I think that it makes sense that if a patient doesn't necessarily have the risk factors that ACOG recommends, but has multiple risk factors, if there is no effect of the low-dose aspirin, then I think it's probably a good idea to put them on it.
But most all the studies showed a small difference, right?
Sure.
Small positive difference, and they weren't powered to be able to say that was statistically significant. I mean, most of the time when there's really not a difference there, if you repeat that study over and over again, you get
Get a good
you know,
result.
it's just a random event, so you're gonna start getting positive and negative results, right?
Yes, sir.
And these studies were all positive, I mean, they were all had small
Just weren't significant.
positive numbers.
Yes, sir.
You know, and so really to be able to answer the question, see small numbers, you're gonna have lots and lots of patients, so you have to put a lot together. So really, if you really wanted to answer this question, you would need 50,000, 100,000 patients, right?
Yeah.
You know, so, you know, high-risk patients, I mean, that's easy. You're right, it's the moderate risk patients, because how many patients do we have in the clinic? I mean, first of all, obesity in our clinic is.
Yeah.
Go back to the risk factor.
Yeah, so null parity, age over 35. You look at all those risk factors.
One thing that
So
never came up was like African Americans. Don't they have like a significantly higher?
They have a higher rate of preeclampsia inherently, yes.
Because I never saw it in anything as
Yeah.
far as recommending it.
Well, I think if you took that alone, maybe not, but.
Yeah,
I
when
mean, it
just with
says
maybe the
family
higher-
history, and then there's social demographics, African American race, low socioeconomic
Oh,
status, moderate risk factor, so.
All right. Thanks.